Hello and welcome. My name is Bob Fury. I am a pharmacist, and today I would like to speak to you about one of the drugs that we use in the treatment of Parkinson's disease. This drug has been in use for nearly 50 years and has pretty much established itself as the gold standard in the treatment of the major motor symptoms that we see with Parkinson's, which is the slowness, the stiffness, and the tremors. This drug, of course, is levodopa. And if you're currently not taking levodopa, chances are you probably will at some future point. The reason being is that it has established itself as the gold standard and is the best for those three major motor symptoms that we see. Now, we're all aware of the hallmark characteristic signs and symptoms of Parkinson's, due mainly to a substantial decrease in the production of one brain chemical called dopamine. And the trick is, how do we supplement that dopamine? Well, without using dopamine. And the reason why we can't use dopamine is because it doesn't penetrate the blood-brain barrier. It doesn't get to where we want it to go. We don't need it sitting in the stomach. We need it sitting up in the brain. And it has many challenges when we take that. So for instance, if we give dopamine, it's going to stay in that form and not transmit itself over into the brain. So how do we get around that? We use something called a precursor. And a precursor is something that gets converted into dopamine and can also penetrate that blood-brain barrier. And the precursor that we use is levodopa. And it's been very successful over the years. But before we talk about all the different formulations of that, if you're currently taking levodopa, you've probably seen from the pharmacy, you get your prescription vial, and it will have two names on it. It'll say levodopa slash carbidopa, or carbidopa slash levodopa, depending how they print it. And the reason for that is the carbidopa, interestingly enough, does absolutely nothing for your Parkinson's symptoms. The purpose why we incorporate the carbidopa into that levodopa pill is to prevent our bodies from converting that levodopa into dopamine before it has a chance to enter the brain. Having all that dopamine outside of the brain, which we refer to as the periphery, doesn't do us any good. As a matter of fact, it can make you really sick. It causes nausea, vomiting, hypertension, dyskinesias. So what the carbidopa does is it sort of prevents or protects that levodopa from being converted too soon, leaving it a greater opportunity to get up into the brain. The more levodopa we get there, the more dopamine that gets produced, and the better our symptoms are well controlled. So, and also another benefit of carbidopa is it dramatically reduces the nausea and the vomiting that can often accompany levodopa therapy. So it's a twofold, it's a win-win. It prolongs the time and protects the levodopa from being converted too soon, and it also stops the nausea and vomiting that we see sometimes. So there are many different formulations, as I mentioned. The first one, and probably the most common, is the immediate release form. This is sometimes referred to as a drug called Sinemet, probably because that was the original one that came on the market almost 50 years ago. I call it Sinemet simply because it's 3 syllables versus 8 syllables for carbidopa levodopa. So just we speed things up using it that way. But Sinemet was the first. It's an immediate release product. It kicks in about 30 to 35 minutes, which is great. They also make a Sinemet CR, a controlled release tablet. Um, this is questionable. This has been on the market, again, a long time, but has kind of faded out because of absorption problems. A lot of neurologists have gotten away from this. I personally haven't dispensed much of it, and the little bit that I have dispensed, you seldom see the patients come back for it. Mostly because it's unpredictable in its absorption, and it really hasn't prolonged the on time that you see. For those neurologists that are still prescribing it, usually it's prescribed mostly at bedtime. The other dosage form that's out there is a product called, which I really like, it's called Parcopa. Now, Parcopa is a brand name, but it's designed as what they call an ODT, an orally disintegrating tablet. This is great for patients that have dysphagia or difficulty in swallowing. All you do is take the tablet, you place it on the tongue, not even under the tongue, just lay it on the tongue, and within seconds, it's absorbed into the oral cavity and it gets distributed to the body very quickly. And this is a nice option. But as I said, Parcopa is the brand name. I don't believe the manufacturer is still making it under the brand name, but it is available generically, that I know. The next one that I have is, newer one, Rytari. This is a capsule, and this is interesting. I kind of like this dosage form because it's got two added benefits. If anybody remembers the old Contact cough and cold product, um, their tagline was that it had these little micro beads inside the capsule, and that's what Rytari is. It's a capsule that has hundreds of these tiny little beads, and these beads are coated to dissolve at different times. So in other words, you have the immediate release bead that gets absorbed right away, just like you were taking an immediate release tablet. And then you have the next level, the intermediate level, that gets to dissolve when the first one wears off. And then finally, the extended one kicks in when the intermediate stops. So the advantage here, of course, is that let's say you're taking your immediate release Cinemet or levodopa carbidopa every 3 hours, you might be able to extend that by using Rytari up to maybe 4 or 5 hours, even 6 hours, which would be a great benefit. You're not popping pills all day long. The other nice feature I like about Rytari is, again, if you're having difficulty swallowing, you can open up the capsule and sprinkle those micro beads on maybe 2 or 3 tablespoons of applesauce and just take it down that way. So it really is very versatile. Not everyone's going to be a candidate for that, but definitely speak to your neurologist and see. The next one I have is, this is brand new. This just came on the market about 8 months ago, in November of 2021. It's called Divvy. I think I'm saying that right. It's spelled Dhivy. Kind of a cute name because what it is a oblong tablet that's divided or divvied up into 4 separate segments. So you can really tweak your dose of the levodopa carbidopa by just snapping off individual pieces. Or again, if you're having difficulty swallowing, you can take each piece and swallow them individually, or if you can swallow the tablet whole. It's up to you. So it's really another alternative to managing your symptoms very, very accurately. The next one isn't really an oral dosage form. This is what they refer to as an intestinal gel. It's called Duopa. Now, Duopa is a little bit more invasive. What it involves is kind of similar to a diabetic who wears a pump. And what the doctors do is they put a tube directly into your intestine, and the other end of it is connected to a pump that you wear. That pump has a room for a cartridge to fit into, and that cartridge has about 16 hours worth of carbidopa levodopa that's slowly administered throughout the day, which really you don't get those peaks and valleys. Now you're getting a nice smooth release of dopamine. So that can be very advantageous. It's not for everyone, obviously, because it is somewhat invasive, and you typically see this in patients who are having a lot of dyskinesias or frequent or prolonged off time. Um, Duopa might be an option for that. The final one I'm going to mention is different also. It's not an oral form in the sense that you swallow it, it's an orally inhaled capsule that goes into a little chamber on an inhaler, and you actually breathe it in. It doesn't contain carbidopa, it's just levodopa. And the advantage here, we use this mostly as a rescue medication for those patients who are experiencing a great amount of off time and they need something very quickly to get into their bloodstream. The drug name is called Inbrija, and we can do a whole segment just on that, but that's another option. Also, how about side effects? The biggest and most important side effect is going to be nausea and vomiting, which I said you can decrease the chances of that happening by taking it with a little cracker or a piece of toast. but not a protein. And I'll explain why in a second. The other side effect is orthostatic hypotension. What that really is, it means that you see a drop in your blood pressure in respects to a change in your posture. So if you're going from a sitting to a standing position too quickly, and I think all of us have had that at some point in time when you get a little lightheaded and woozy. But unfortunately, in Parkinson's, everything moves slowly. So ordinarily, your body would compensate for that change in position very quickly. But in Parkinson's, nothing really happens very quickly. Things take time. So what happens is now you're standing up and the blood hasn't had a chance to get back up into the head, and you get lightheaded, woozy, and fall. Falls are brutal. They're terrible. That's the last thing we want to see happen. We're talking breaks, and I've seen many come into the pharmacy with a cast on or a sling or a cracked elbow, a broken wrist, a bent back finger, even facial lacerations and head trauma. So we really don't want to see that happen. This is something that your neurologist can and will monitor. He'll take your blood pressure when you're sitting and when you're standing and measuring the difference, and they'll monitor that very closely. If it becomes a problem, we actually have medication that can treat orthostatic hypotension. The other items that are side effects is confusion and hallucinations. Now, typically you'd see this in older patients or patients that have an associated dementia on top of the Parkinson's. Hallucinations and confusion it seems to be more common in that population. And the last and final one would be the dyskinesias. And a word on that. There's no doubt dyskinesias are a concern on levodopa therapy. With all the chatter that's out there on Google and FaceTime and the internet, YouTube, certainly it is an issue. But let me make one thing very perfectly clear. Not everyone is going to get dyskinesias who's on levodopa. You can get dyskinesias on levodopa for being on it for long periods of time. Typically, we would see it more common in the younger patient who's diagnosed very early and is staying on it for a very long period of time, or in those patients that are taking a very high dose for a long period of time. They seem to be more prone with dyskinesias, but not everybody gets it. And quite frankly, those that do get it, some of them don't. It's just a nuisance. It's slightly bothersome. It doesn't affect them at all. I had a patient one time come in and tell me that he would rather deal with the dyskinesia than deal with the slowness, the stiffness, and the tremor. He was like, if I can get those three under control, the dyskinesia is fine. He still works, and he worked in his garden in his days off and whatnot. It didn't affect him at all. So it's important to realize that not everybody's going to get that. Another misconception that goes along with this is I did mention it as the gold standard, but it doesn't cure all of them. It doesn't do anything for your posture. It's not going to help with mood or memory or balance. The levodopa therapy is best used for slowness, stiffness, and tremor. And I'm going to throw in a wild card here, tremor. Not everybody does so well with tremor. I've had patients say that they've come into the pharmacy and have told me that it was a wonder drug. That resting tremor that they had, almost completely gone. Versus patients that have said it didn't do a darn thing. My slowness and my stiffness, great, but I can't seem to get rid of that tremor. And anything in between flies when it comes to the tremor aspect. So if you're on levodopa and you're getting great results for slowness and stiffness, but men's amends as far as your tremor, speak to your neurologist. There are add-on products that we can do, perhaps maybe even just adjust the dose of your levodopa, carbidopa, and they can get that tremor back under control. But the other two symptoms seem to do better. The other item that comes up that I get asked sometimes is, does it lose its effectiveness over time? And my general answer to that is no. If you're taking it for slowness and stiffness and it's working, it will always work for your slowness and stiffness. The problem is, as time goes on and your Parkinson's progresses, you may require more of the drug because your symptoms have changed. So in a sense, I can understand how a patient could misinterpret that and think that, oh, the medicine's just not working anymore. The doctor had to increase the dose. No, the drug is doing what the drug does. The Parkinson's has changed, and that required a different dose, which again is fine. The neurologist will adjust the dose, tweak it, add a little bit more perhaps, or increase the frequency during the day, and it will easily eliminate those symptoms again, like it always did. A final note before we close, and this is important. Don't avoid or delay starting your levodopa therapy before you allow your motor symptoms to get in the way of what you want or need to do. Let me say that again. Super important. Don't delay therapy with levodopa or don't avoid it entirely by allowing your motor symptoms to get in the way of what you want or need to do, because we can fix that. Your neurologist can definitely, if not levodopa, there are many other tools in his or her arsenal that they can use to address those issues. And for some patients, it can be life changing, absolutely life changing. So please speak to your neurologist. Don't let those symptoms affect you adversely. And with that, I hope you've learned at least one new thing about your levodopa, carbidopa. And I do want to mention another food-drug interaction. I mentioned proteins, but one we don't think of often that just came to mind is fats. If you're going to go out and have a double bacon cheeseburger and then take your levodopa, don't do that. What happens is fats, when we consume fat, it delays gastric emptying. So whatever contents, including your pill that you took with that hamburger, is still sitting in your stomach. And if it's in your stomach, it's not in your brain where we need it. So it's going to delay your on time. So ideally, again, I will emphasize the levodopa should be taken on an empty stomach, full glass of water, preferably 2 full glasses of water every day, every dose, to help flush it out of the stomach and into the small intestines. That's the best way to take it. If you're taking an iron supplement, perhaps for anemia, or you're taking a multiple vitamin with iron, don't take it with your levodopa. It will it will combine with the levodopa and make it unavailable for absorption. So keep that in mind when you're taking it, and I'll see you on the next one.